I'm Felicia Greenfield, Executive Director of the Penn Memory Center and a psychotherapist newly in private practice in Philadelphia. I'm delighted to moderate today's discussion on anti-amyloid treatments for Alzheimer's disease with my friends and colleagues, the distinguished Drs. Stephen Arnold and David Wolk. Dr. Stephen E. Arnold is a professor of neurology at Harvard Medical School and translational neurology head at and managing director of the Interdisciplinary Brain Center at Massachusetts General Hospital. Dr. David Wolk is professor of neurology at the University of Pennsylvania, director of the Penn Alzheimer's Disease Research Center, co-director of the Penn Memory Center, and co-director of Penn's Institute on Aging. I'm going to now ask our panelists to give us an update on the progress of anti-amyloid therapies to date. First, I'll ask Dr. Arnold to explain what anti-amyloid therapy is and how we got to this point in the treatment of Alzheimer's disease. And then I'll ask Dr. Wolk to tell us about the data that led to the approval of lecanemab. Dr. Wolk, or Dr. Arnold?
Okay, thanks so much, Felicia. And it's really a pleasure to be here and speak with you all. We are really excited to be in a new era of medical care for people with Alzheimer's disease. And before Dr. Wolk introduces us to the new anti-amyloid therapies for Alzheimer's disease and tell us how the studies went that led to the approval, I'd like to give a little background and history of how we got here, describe what amyloid is and why this is an important target for Alzheimer's disease treatment. The first thing is that the term amyloid itself can be confusing for a lot of people because it's really a general term for misfolded proteins. We have hundreds of thousands of different kinds of protein molecules that make up the different cells and tissues of our body. And many of these protein molecules are dissolved and floating around either inside or out of the cells, bathing the brain or the heart or the liver. All protein molecules have a physical structure. And for some proteins, the structure is more unstable than others. And this makes them vulnerable to folding up and snagging each other, and then forming fibrils and clumps of aggregated protein. So amyloid, the term amyloid is the general term for these protein fibrils. And these fibrils and the aggregated fibrils that clump up can cause damage to the surrounding tissue. Now, there are a number of different proteins that can form these amyloid deposits, and different proteins are are associated with different diseases. So, for instance, there's a protein called AL amyloid or amyloid light chain that can accumulate in the heart or the kidney and cause heart failure or kidney failure. In Alzheimer's disease, the protein is called beta amyloid. And this accumulates in the brain and forms these plaques and tangles that really define the disease. So on the slide, this is a little historical slide to show that back in the 1890s is when Alois Alzheimer looked through the microscope at the brain tissue of a woman portrayed on the left, a woman named Auguste Dieter. And she had dementia, and when he examined her brain tissue under the microscope after she died, he described the plaques and the tangles that we now use to define Alzheimer's disease. But it wasn't really until the 1970s or 80s that people really started looking at these plaques and tangles in more detail. Prior to that, we called dementia senile dementia. And while most of those senile dementias were Alzheimer's disease, we really didn't understand the process at all. But it was in 1984, actually, that the beta amyloid, as the specific protein molecule that forms these plaques, that is when that was first described. And a couple of years later, there was another protein that forms these fibrils, that misfolds and forms these fibrils called tau. And we found out that that was the major protein that causes the tangles. And since the discovery of those two protein molecules that form these plaques and tangles set off now decades of research into, how do they form? What's happening? Can we actually get rid of them? If we do get rid of them, what happens? And it has taken us decades and numerous failures of different treatments and billions of dollars of trials, clinical trials, to come to the point that we are now at. So let me tell you a little bit more about the amyloid and also tau. Dave, can you give me the next slide? Okay, so amyloid plaques that you see over, on towards the left side of the cartoon, this is brain tissue that has been stained to look at the amyloid. And in the little kind of schematic that I have here, amyloid are protein molecules that we all have. They're all normal, these beta amyloid molecules, and they're secreted from cells, and they float around, and they actually may be helpful for the health of different cells in the brain. But as I said before, sometimes these beta amyloid proteins can misfold and crumple up, and they form, little aggregates called oligomers that then can clump up even more and aggregate into what we see under the microscope, which is an amyloid plaque. And these oligomers themselves can be toxic to brain connections. And these oligomers and the plaques also kind of elicit an inflammatory response in the brain that also does damage. Next slide. Well, actually, before you go to that slide, Dave, go back once. So the new anti-amyloid immunotherapies are really attacking these oligomers and these fibrils that are in the middle of this little schematic cartoon. And we actually have found that the anti-amyloid therapies that were tried before and failed, that attacked the single protein molecules, they were not effective, and they may have even made people a little bit worse. Next slide. So there's the amyloid plaques, and then there are the tau tangles. And tau is another protein that, instead of being secreted outside of cells, is within the cells. And that also can misfold and aggregate into these fibrils that we call neurofibrillary tangles. And that can disrupt the activity of the brain cell, ultimately leading to the brain cell dying. Next slide. So now we are in a position, and this is now a classic graph of the way these pathologies of Alzheimer's disease form and progress. But we're now in a position where we have biomarkers. We have spinal fluid tests, we have PET scans, we even have blood tests now that can measure whether there is amyloid or tau that's developing, so the beta amyloid plaques or the tau tangles, whether they are developing in the brain. And this has been, these biomarkers are a total game changer for us, because we can identify with a high degree of certainty that it is amyloid or tau that is causing someone's cognitive difficulty. And we can even detect that very early. What this graph portrays is that we see some changes in the beta amyloid, perhaps 10 or even 20 years before someone has their first symptom. And that's followed shortly after by the tau fibrils forming and accumulating in the brain. And it's only when we start to see some degeneration, when the injury of those amyloid and tau pathologies, when that injury occurs, that we start to see the memory difficulties. And this really is extraordinarily important because it gives us a window where we can see the disease forming at the earliest stages. And perhaps that is the optimal time for treatment. So I'd like to turn it over to Dr. Wolk at this time to tell us what we have learned now and why these anti-amyloid therapies have been such at least a scientific advance, and we're now able to offer them to patients.
Thanks so much, Dr. Arnold, and really great to be here today with you all. And I think that was a really nice lead-in for me to kind of briefly go over why it was that lecanemab or Leqembi was the first fully FDA-approved drug for Alzheimer's disease in over 20 years, and the first that is considered "quote-unquote" disease-modifying in the sense that it slows down the course of the disease. So, as Dr. Arnold, I think, really nicely showed, there are two main protein aggregates or two main clumps of proteins that occur in the brain with Alzheimer's disease. There's the amyloid plaques, and then there's the tau-based neurofibrillary tangles. And I think as also what Dr. Arnold showed was that the amyloid does seem to be an earlier or an antecedent event in the course of Alzheimer's disease. The tau tangles are actually a bit more tightly linked to the injury to the brain and then to symptoms of the disease. And so in thinking about treating Alzheimer's disease, one might want to consider removing the plaques, as is done here, but with the hope that it actually benefits some of these downstream effects on the brain that might also be affecting things such as tau in the brain. So to get specific, the one fully FDA-approved drug is called Leqembi or lecanemab. There's another drug that I think we'll talk about at some point during the course of today called donanemab that is still being considered for approval with the idea that it's pretty likely it will over the next month or two. But lecanemab is an antibody. It's a monoclonal antibody, meaning that it is a single type of antibody that binds to amyloid beta, which is the protein that makes amyloid plaques. But as Dr. Arnold mentioned, it binds to it in the form of oligomers or protofibrils, which are sort of the earlier stages of its clumping together before it forms the plaque itself that we can see under a microscope. And in essence, these are not antibodies that you produce. Normally, we produce antibodies to all sorts of things that are foreign to our body. These are antibodies that are given to us through infusion, and they bind to amyloid with the idea that they would remove these toxic forms of A beta. It's also worth noting, though, that they do bind to some extent to the plaques and to some other forms of amyloid as well. But again, they most strongly bind to the oligomers and protofibrils. So really the definitive study for us for this drug to have been approved was something called Clarity AD. And that was a phase 3, very large randomized controlled trial. Phase 3 trials for medicine are trials that are really looking at whether or not a drug works. And those are the trials that go to the FDA for decisions about approval. This trial enrolled around 1,800 people who were at very mild stages of Alzheimer's disease. So these were people who were in what we call the mild cognitive impairment stage, which is when people have memory and thinking problems that are more than you expect for age, but they're still able to function pretty well in most of their activities of daily living. It also included people with mild dementia, due to Alzheimer's disease. And dementia is when you're starting to have a little bit more trouble in your capacity to do some of the activities that you would normally do, like balance your checkbook or not get lost when driving. In order to be in the study, and this was actually one of the great advances in general in our field, is that you had to have a positive amyloid PET scan. So you had to have evidence using those biomarkers that Stephen mentioned earlier of the fact that you had the pathology of Alzheimer's disease. And why that's a big advance is in many of the trials over the last 2 decades, before we use these biomarkers in our trials, many patients who were included in Alzheimer's trials didn't actually end up having Alzheimer's disease as the underlying diagnosis. So this is a population we knew had Alzheimer's disease. And I think one of the really impressive things about this drug and the figure that you can see here is that those that were treated on the drug had really remarkable removal of amyloid plaques from the brain. And so in this figure, the orange is the people treated with lecanemab, and you're looking at the change in the amyloid plaque burden over time with the treatment. And the simplest way to think about this is by the end of the trial at 18 months, 2/3 of those people who had a positive amyloid PET scan, if you looked at their PET scan at that point, it would be considered negative. So a radiologist wouldn't be able to see evidence of amyloid in the brain in 66% of those people, or around that number. So it really remarkably worked in removing amyloid from the brain. And I think, for people who've been in this field for a while, if you just take a step back, it's a remarkable thing that, one, we can see the pathology of the disease using these special tests, and two, we could develop a therapy that could actually change the pathology of the disease. Okay, that's nice to see. I should also say there was some evidence, some fairly convincing, but I think there still needs to be more data out there, that the drug also affected some of the downstream markers of tau pathology in the spinal fluid and blood, and a little bit on some imaging measures of tau, although it was in a very small number of people in this particular study. But the bottom line is, at least we were starting to see some signal of some of the downstream effects of amyloid on the brain that might suggest that this drug could have a benefit. None of this would allow the FDA, though, to approve the drug. These are just sort of supportive features. Really what you want to see is, does it have an impact on patients in terms of their thinking and in terms of their function? And indeed, there was evidence of this over the 18 months of the study. And depending on a variety of different measures that you could look at, there was anywhere from about a 25 to 35 or 40% slowing of the disease over time. So for example, on the left is a rating scale of the degree of functional and cognitive impairment in patients. And those treated with lecanemab show less change over time compared to the placebo group. And so there's an advantage for the lecanemab group at 18 months. And on the right is one that shows a measure of function, where again, there was a significantly slower decline in the group treated with lecanemab versus placebo. So there was clear evidence of slowing of progression of the disease over this 18-month period. And that is the kind of definitive data that led the FDA to approve the drug. Now, there's some debate about what this really means for patients, and at least one way to think about this, and I think we could probably discuss a fair bit more as this podcast goes on, but one way to think about this is, well, how well did this drug reduce the rate of progressing to a clinically meaningful difference over time? So how often did someone go from a more mild stage of disease to a more significant stage of disease over the 18 months of the trial? And overall, there was about a 25% reduction in that progression. So 1 in 4 people didn't go on to a later stage of disease over this period of time compared to the placebo group. one important thing to keep in mind, and this is one of the challenges of doing these kinds of studies, is Alzheimer's disease is a very slow-moving disease. And even in the placebo group, about 2/3 of people don't progress over an 18-month time frame. And so when we talk about the size of the effect of these drugs on outcomes, we have to keep in mind that we're trying to change a slow-moving disease and be able to see signal of change. And so if it's not changing a lot just in general over 18 months, the absolute quantity of a change that you can affect with a drug is going to be relatively small, even though percentage-wise it might have a significant effect on disease slowing. But again, these are the data that really led to the approval of this drug. And so I'm going to now turn it back over to Felicia.
Thank you. Thank you. That was a helpful and informative background and explanation of Leqembi. Some questions have come in, and I'm going to just pause those questions until right before the end of the session, but folks can still keep asking questions as we go along. I want to get into kind of some of the specifics about people who might benefit from taking this drug, but I thought it might be a good idea if we could I thought it might be interesting to hear about our experiences at our respective institutions so far. I know that at Penn, there's been a strong interest and high demand for people interested in lecanemab. But there are challenges because, this drug requires infusions, and there's additional scans and imaging. So I think it might be interesting to start this conversation by talking about what some of our biggest challenges have been, both at Penn and at Harvard. So I don't know, Dr. Wolk, do you want to go first and talk about some of the challenges we've been seeing at Penn?
Sure. So, I think this is really a major shift in how all of us practice neurology or dementia care for patients with Alzheimer's disease or suspected Alzheimer's disease. And so, as Felicia alluded to, it's really complicated administering these drugs. They involve infusions every 2 weeks for lecanemab. They involve monitoring with MRI scan at various time points to assess for some of the side effects. They involve a fairly detailed evaluation to see if someone's appropriate for lecanemab. And all those steps require coordination across different disciplines and fields and scheduling and insurance and other related issues, that it really required a health system-wide approach to sort of developing the infrastructure to allow us to start to give patients these drugs. We went through a process of developing that program that really took us from when the drugs were approved in the middle of the summer to around October or November to have all the sort of pieces in place so that we could administer these drugs as safely and effectively as possible. And we've actually now, I think, treated somewhere around a couple dozen people with the drug, and we have a relatively long list of people that are kind of on the launching pad to starting with the drug. The other, I think, side of challenges in terms of, in addition to sort of setting things up, is actually having the workforce to manage patients with these conditions. So as everyone here, I'm sure, is aware, Alzheimer's disease is an extremely common position, or has extremely common diagnosis and condition. And the number of physicians who really specialize within this area is very, very, very small relative to the population of patients with these conditions that would potentially qualify for lecanemab. And so we've really had struggles and have tried to think about ways to increase our capacity as best as possible so that we could move people through this process. And I would say, if there's a bottleneck now, that is the biggest bottleneck for us is being able to see all the patients we would want to evaluate for these drugs relative to the number of clinicians we have to move that process forward. But maybe I'll turn to Dr. Arnold to give the MGH experience.
Yeah, so I think, our experience has been very similar. This is a complicated treatment. There are, we haven't talked yet about some of the safety concerns and possible side effects of the medicines, which, while rare, can be serious. And with the, ethic that, safety first, first do no harm, the setting up, getting the clinicians who treat memory disorders in our group together, bring everyone around the table over the course of months. We've been doing this now for over a year, and coming up with protocols, coming to consensus about who is the drug right for, who is the drug wrong for, that we don't want, organizing schedules, dealing with radiologists so that we can decide on criteria by which we're going to judge MRI scans to see whether it's safe for someone to be on the medicine or to continue on the medicine. So many different moving pieces that really we actually formed a clinic, a specialty clinic for, amyloid treatment, with about 15 different physicians at our institution, each one of whom takes a week or 2 weeks of practice for this. And, I think it's been, we just opened it about a month and a half or 2 months ago. We've got a long list of people that are interested. We've got a long list of people that, have already been through the clinic and are waiting for the infusions. But again, the process is very slow. We have not yet infused a patient here at Mass General, and the reason is because we need to train the nurses on the infusion service into some of the particulars of administering the drug. So this has been a slow and I have to say, appropriately careful rollout. And this is whether we're talking Penn, MGH, or other, at least academic medical centers, people are going into this very, very cautiously.
Thank you. Either one of you can take this question. Who would you say would be the ideal candidate for Leqembi?
I'll start, and maybe Dr. Arnold can fill in gaps. I think right now, and some of this really reflects the caution that Dr. Arnold referred to, is we're very much trying to keep to the way the clinical trials were designed in terms of who we feel is appropriate for the drug. And so really we want people who are in very early stages of Alzheimer's disease, so people who have mild cognitive impairment or very mild dementia. And some of that is based on cutoff scores that we use, and some of that's based on clinician intuition about what degree of impairment someone has. That's one thing just to start with. And actually there is some data that's come out, some of this secondary analyses of the data from this trial, as well as with this other drug called donanemab that's very similar, that the more mild you are, even within that mild range, seems to be associated with even better outcomes. And there is this argument that focusing on amyloid at earlier stages, since it's an earlier event in the disease process, may be when it's most advantageous. In addition to that, there are other factors that may influence your risks of the drug. And those include evidence of what we call amyloid angiopathy, which is a complicated term, but basically, when amyloid accumulates in the brain, it also can go into blood vessels and cause those blood vessels to be leaky. And it's a pretty common thing we see in Alzheimer's disease, just in general, even untreated patients. However, one of the side effects of the drug is that when it's given, people can have more leakiness and have what's called edema or some swelling around these blood vessels, or can have even little tiny bleeds of from the blood vessel that can be detected on an MRI scan, and very rarely can have a much larger bleed in the brain. And so what we look for on the MRI scan when we're assessing for a patient is, do they have evidence already before we started treatment of these little tiny bleeds in the brain, which again can occur just with normal Alzheimer's disease. They're very, very tiny, even though you can see them on an MRI. They're actually much smaller than what we can see with imaging. So they don't necessarily, you wouldn't necessarily know you had them. But it seems that the more of those that you have, the higher risk you have of this side effect. And then another feature we look for to stratify both potential benefit and risk is someone's genetic status. So there's a gene called the apolipoprotein E gene, which is a gene that is the largest risk factor for Alzheimer's disease genetically if you carry a copy of what's called the E4 allele of this gene. So we all have 2 copies of every gene. We have 2 copies of apolipoprotein E, and the E4 one is a risk gene for Alzheimer's disease. And having 2 copies, there's even a higher risk for having Alzheimer's disease. And the reason why that's important here is that also seems to be a risk for the side effect of the little tiny bleeds I mentioned and the swelling in the brain. And so people who have 1 or more copies of that gene progressively have more risk. And so the most ideal candidate would be someone who's very, very mild, is very, very healthy, and doesn't carry this risk gene for Alzheimer's disease and has an MRI without evidence of these of amyloid angiopathy. When you have more, if you have 1 copy of that allele, that increases your risk some for these side effects, and if you have 2 copies, that increases your risk even more. And so those are the kinds of things we discuss with patients in terms of what their risk-benefit balance is. But maybe I'll let Dr. Arnold expand upon some of that as well.
Sure. Yeah. So, I was thinking about this before, and, we only really know, in terms of who it's beneficial for or who's at risk, we only really know the scope of people that have been studied in the research so far. So, these were people with, as Dr. Wolk said, mild cognitive impairment or very mild stages of dementia. Would it help people who have more advanced disease or more dementia? We just don't know. I think that if we look within the range that Dr. Wolk just talked about, and seeing that people who are at the earlier stages of the disease have the best response, and those who are a little bit more advanced and have mild dementia, that they may be less likely to respond, I think we can extrapolate to say that it probably won't be that helpful in people that have moderate stages of dementia. Now, another big question, and there are several big studies going on now to look at that. What if we could actually treat people before they develop memory problems, but they're already developing that amyloid in the brain? Again, we don't know. We would like to think, we hope, that we'll be able to, prevent the emergence of forgetfulness and memory decline if we can see if someone's developing amyloid. But, the bottom line is that we really don't know at this point. And I think that that's something that we're looking forward to in the future as these current research studies unfold. And so, for all of you, either caring for someone with Alzheimer's disease or worried, if you can participate in research so that we can learn these things, it'll be a great service to the world to have a prevention for Alzheimer's disease. beyond that, I think, some things that Dr. Wolk and I have discussed in the past. He mentioned that people earlier on, and that even, we can now use PET scans to measure amyloid. We can use PET scans to measure tau. And you could actually see that the people that have the lower levels of tau in the brain when they're treated also seem to have a more beneficial response. Again, kind of saying that the milder the disease, the more likely you are to have an impact of it. There are some odd things in the treatment too that I don't quite understand yet. If you look at some of the data for the lecanemab, men seem to respond a little bit better than women. I'm not sure why. I'm not even sure whether it was significant or just chance. And then people that had the older people tend to respond a little bit better than younger people who had maybe more early onset Alzheimer's disease. And early onset Alzheimer's disease tends to be a more aggressive disease, so it may be harder to really fight it and make an impact. Again, these are kind of little interesting points that came up in the study that we don't really understand yet, but I think are worth kind of keeping an eye on.
Thank you for, giving us all of that information, Dr. Wolk and Dr. Arnold. We're entering a new era in the treatment of Alzheimer's, which is incredibly exciting and hopeful. What do you think is next? Dr. Arnold, do you want to start?
Sure. Yeah, so, I like to frame this advance that we have as a huge scientific advance, but a modest clinical advance, meaning that as we saw, when Dr. Wolk showed the graphs of people, there was clearly a difference between people that were treated with the drug versus those who were not treated with the drug. But still, people were getting worse, okay? The overall, on average, people were declining. And so why I take real heart in this is that this is the first time after, again, years, decades of research, that you can actually treat the biology of the disease, treat the pathology, the amyloid, and lower it and actually have it make a difference clinically. And I can't underscore the importance of that. But the clinical effect is modest, and we need to do better. We need to do better in a lot of ways. One, it needs to be more effective, okay, because the effect is modest. I think we need to make it safer because, again, I said serious side effects from this are quite rare. But those that brain swelling or little evidence of the brain swelling or the micro bleeds, they can occur in 20% of people, 25% of people, and you have to stop the treatment if that occurs, at least for the while until it resolves. Something like Leqembi, where you have to go every 2 weeks for an infusion. That's a huge burden and a huge expense in terms of time, in terms of transportation, in terms of just the cost of the drug. I think the company that makes Leqembi is now making a subcutaneous formulation and the results. So this is something that you can inject yourself at home once a week. That may be available within a year or two. We don't know yet. That is something, a way that we can get it better, less burdensome for people, and possibly less expensive for people to take it. There will still be the side effects. And then, to the point that, okay, you can get amyloid levels in the brain down to indistinguishable from people without Alzheimer's disease. And yet people are still getting worse. That to me tells me that Alzheimer's disease is more than amyloid, and maybe even more than amyloid and tau. And so I think combination therapy is in the future, right? And I think we have to kind of look at the lessons of cancer. You know, childhood leukemia had like a 90, back in the 1940s, had like a 90%, 95%, death rate. And then, Sidney Farber started treating people with a drug, and he got it down to 85%. So 15% were surviving. And then combination therapy in cancer, using three different approaches to tackle a difficult disease like heart disease, Alzheimer's disease, cancer. This is what we've learned in some of these other fields that have been so successful. And I think that that's what the future also holds. As we look at, we're going to have to deal with amyloid because it does seem to be, one of the earliest and driving forces of that. But beyond that, we're going to have to do better with tau. We're going to have to do better with inflammation. We're going to have to do better with some of the other metabolic or other things that are part and parcel of the Alzheimer process. And I'm very optimistic that we're going to be we're doing that now. Dr. Wolk, I don't know if you want to add something to it. So.
Yeah, I mean, I agree entirely with what you said. I am pretty optimistic about the future, and I think a few points. I think in it, as Dr. Arnold mentioned, the benefits of this drug on average are pretty modest, but that it's a major scientific breakthrough despite that modesty. And I think it also is a major breakthrough in another way in terms of a salubrious side effect, if you will, which is that it's forcing us to now really try to characterize our patients as much as possible using the tools that we've used in research for a number of years, but that hasn't come into clinical practice, which is obtaining, PET scans, using spinal fluid studies, potentially with blood now, there's an opportunity to measure a variety of different factors, incorporating in genetics and other types of information. I think, we have a real opportunity to now move into what in the cancer world is referred to as this precision medicine era, where we can really tailor therapies and treatments to an individual patient. Because if there's one thing I think anyone who's been in this field has learned, is that patients are incredibly heterogeneous in terms of the course of the disease, the timing of the disease, the nature of their symptoms, other pathologies that are in the brain, even where Alzheimer's is in the brain in terms of its own pathology itself. And I think this drug forces us to start to take the kind of information we can use in research and apply it into our clinical populations. And my hope, and something we're trying to push here at Penn, is that we actually incorporate more research into our clinical practice so we can see these drugs in the real world. And what I think will happen, in addition to other drugs and other kinds of targets, we'll get better at using the drugs that we have now. I think we'll better learn people who are going to be more responsive to them versus not. I think there will be an evolution in these drugs in that there are already approaches that might make them safer in terms of the side effects. So at least we're lowering the risk part of the drug. And I think there also will be potentially delivery mechanisms that will help. And then I think the frontier that, Dr. Arnold also alluded to earlier is if these drugs work in people who are symptomatic, there's pretty good reason to believe that they might work in people before they're symptomatic and delay the time to when people would develop symptoms in the future. And so I think there's a great deal of hope that this drug opens up. One is just a conceptual hope that, yes, we can modify the disease, which I think, even though we all kind of believe that, took 20 years to show that we can do that. But two, I think it just changes the way we practice medicine in this population that will ultimately have downstream effects to really move the field forward.
Let me just add, I wanted to kind of, I like what Dr. Wolk just said, and I wanted to add that, the future and kind of this precision medicine is what has really made such a difference in cancer. And I had talked about the childhood leukemia having like a 95% mortality rate. Well, now it has a 95% cure rate. It took decades, but it's there. And I think that we can look to a future like that as we understand Alzheimer's better through the research, which, is now starting to bear real fruit.
Thank you for concluding on that hopeful note. We have an engaged audience. We have a number of questions that we probably won't be able to get through in the next 10 minutes. So I'm going to just kind of sift through and ask a few that are related to some of what we talked about. You talked a lot about amyloid plaques and tau. I have a two-part question. If a scan came back positive for amyloid plaque, does it always mean the patient has tau as well? And the second part of that question is, does an MCI diagnosis with a positive amyloid scan definitely mean an Alzheimer's disease diagnosis?
I can take those. Those are challenging and really insightful questions. So to the first, there are most certainly people who have amyloid in their brain who, at least based on tau PET, we can't see evidence of downstream tau pathology in those patients. And there's a thought, or the argument is, that those are individuals who are at an earlier stage of disease. And if you remember the curves that the graph that Dr. Arnold showed earlier, there's an argument that amyloid elevates first, and then a number of years down the road, there's a development of tau pathology. And in fact, when we look in cognitively normal older adults, about a quarter of them have evidence of amyloid in their brain. And if you break down that quarter more, less than half of those people actually also have tau. And again, the thought is that those that don't might develop it at some point in time, although we don't know that for sure. What we do think is the case, though, is that you don't really start developing symptoms of the disease until you have some of this downstream tau in the brain. And so it is certainly possible, because it's common to have amyloid in your brain as you get older, because it's just a very prevalent disease, that you could have another cause of cognitive symptoms, have a positive amyloid scan, but it's not Alzheimer's disease that's driving the symptoms that you're having. And that would be particularly in the case if someone had low levels of tau. So for example, there are cases that have been reported of people who have a different form of dementia, like frontotemporal dementia, who have a positive amyloid scan. Pathologically, when those patients have gone on to autopsy, it's really the frontotemporal dementia that was the dominant disease that was driving their symptoms. And so if you have mild cognitive impairment and you have a positive amyloid scan, but don't have evidence of tau, it is possible something else is causing your symptoms. All that being said, at least the way these trials were designed, they wouldn't make that distinction. And there's even some data in those that when you look at the people who had the lowest levels of tau, although not really well studied in people who have absent tau, but low levels of tau, those people might be the people who respond best to the drug. And so I think that's one of the kind of nuances and complexity that we're dealing with the drug. And I think something we will again learn over time as we treat people with this is, do you have to have some tau, or should you have no tau in terms of your likelihood of response?
And how about the second part to that question? If you answered it, I was reading through the questions. So.
Yeah, no, I did.
Okay, thank you. Then there's another question about the study that was conducted over 18 months. And, how long would you say it takes for the plaques to be completely removed? And kind of a part two to that question is, how do we know if the drug is having an effect on someone, if they continue to show decline over the course of, say, maybe 13 to 15 months?
So I guess I'll field this. So if you look at the curves, so they in the studies for Leqembi, and then we haven't talked much about donanemab yet, but it looks like much of the amyloid clearance occurs within the first 6 to 9 months of treatment. So it's actually relatively rapid. That you're sucking out the amyloid from the brain, which is really encouraging. And then there's like a tail, like everything, where you're just cleaning up what's left. But the biggest impact seems to be within the first 6 to 9 months in terms of reducing amyloid, and tau likely follows that. Clinically, it's more challenging because as we said, the measures that we use aren't as good, and but there is a general kind of correlation with amyloid removal and improvement, or let's say less decline, in that. There was another point that I wanted to make about that, but so the second question, Felicia, was
How do you know
pointless.
if
Oh,
what
how
they've
do you know?
decline?
That is tough. Does it really take 1,000 people to know whether something is going on? And the way these studies and measures are designed, it does. I think that we can personalize our evaluation and our assessments of people. We are in a new era of biomarkers where we can track things. We're in a new era of using these sort of digital tools to assess memory much more precisely. And so I think that there are opportunities to know within the individual whether it's changing the course of their disease and also their clinical profile. It's tough, but I think that we can do it. It's not widely done. Just going to the doctor and saying, I feel better, I not feel better, it's very imprecise to know what that means. We all have good days and bad days. How do you kind of accumulate the data to know on average whether you're stabilizing or whether you're going down? It's tough. And we're all looking for ways to better assess people clinically.
Dave, did you have anything to add?
No, I agree. I mean, I think that's, I think it's really tough. I think that, there's first measuring whether or not you're hitting the target with the drug, which is measuring something about amyloid, like a repeat amyloid PET. And my guess is the field will move towards us obtaining follow-up amyloid measures in people to show that the drug's actually affecting the thing that we expect it to affect, which is to lower amyloid in the brain. In terms of knowing whether it is having a benefit cognitively, the problem is you don't have the counterfactual, which is what that person would have looked like if they weren't taking the drug. And the big challenge in Alzheimer's is that people decline at very different rates. So it's hard to know in any one individual whether they're declining slower than they would have if they didn't take the drug. I do think that there is an intuition about that, and there actually are tools that might help us predict what someone who looks a certain way in terms of their amyloid and tau in the brain, we would expect to see them change, and that those kinds of things might be incorporated into our practice. And Just one other larger point I want to make, because we talked about the 18 months and the clearance of amyloid. One thing a couple of things. One is that these drugs, as Dr. Arnold said, tend to clear amyloid, and by, I mentioned by 18 months in the lecanemab trial, about 2/3 of people had no more amyloid in their brain. We don't know right now if you need to not have amyloid in your brain to slow down the disease or not. And to some extent, in an 18-month trial, the faster you kind of lower the amyloid, if it is important to get down to a low level, the more time you have to see if the drug has any effect over an 18-month study. And so I do think what is unknown is what happens at 36 months and 48 months and these other times down the road. And I think if the drug continues to have a modifying effect over that time, I think it'll be easier to see differences from expectation over longer periods of time than over these sort of short periods where the amount of change is relatively small, even in people not treated with the drug.
Now I have a question about side effects. Has there been any noticeable increase in side effects the longer a patient's been on the drug? If not, is there concern for this if the patient's taking the drug for 5+ years instead of the 2 involved in the FDA approval study?
Yeah, I don't, in general, if anything, it's the opposite of that. When people have side effects, it tends to be early in the course of disease, at least the ones that we were talking about, the swelling or the microhemorrhages. And so those tend to occur within the first 3 to 6 months of treatment, when there's a high load of amyloid in their brain. As people continue in treatment, those numbers go down pretty significantly. And that's why the monitoring with MRI scans is much more spread out and not necessarily even required over longer periods of time. There are a number of people who've been into open label phases of these drugs, followed 2, 3, 4 years. And as far as I know, it doesn't seem like there's an increase in side effects as a result of that. We obviously haven't treated people for years and years and years with these drugs to know for sure, and the population of people who have been treated for 3, 4, 5 years is lower. But if anything, the intuition is the major side effects, which again are the swelling and these microhemorrhages, as well as actually in transfusion reactions, all tend to be things that are early in the treatment phase and not later in the treatment phase.
Okay. There's quite a few questions about genes. And I guess I'll ask one here, which is, why is the ApoE4 carrier at a higher risk for hemorrhage? Are there genetic backgrounds that correlate with the response?
Okay, so
you want to go?
do you want to take it, Dave?
I think I'm sure Dr. Arnold might give a more nuanced answer, but a simplistic reason is that in general, there's higher amyloid load in E4 carriers than non-carriers, and more of this amyloid angiopathy, where the amyloid's in the blood vessels, and that combination seems to result in people as having more of this side effect. In general, in Alzheimer's, even though ApoE4 is a risk factor, about half of people with Alzheimer's don't have that gene. So it's really just a risk factor, but it happens to be a risk factor that interacts with the risk of this drug, a risk factor for Alzheimer's that interacts with the risk of the drug.
And then I guess just one more question on ApoE. What if somebody has one copy of ApoE4 and one copy of ApoE2? Is that a good, combination for treatment or not?
So that would be I would say that would be a good, I'm not sure whether there's real data because the ApoE2 is relatively rare. But we consider the treatment safe for people with one copy of the ApoE4 gene. One copy of the E4 gene increases your risk. 2 copies of the E4 gene, as Dr. Wolk said, increases your risks considerably more. E2 is actually a little bit protective, and it decreases the risk. So I don't know what the data is, but if anything, I would think it might decrease your risk for the side effects a little bit, but I really don't know.
And one thing, I guess, just to bring up with the E4 and risk and risk in general, and that I have found, at least in my experience in dealing with patients, is a lot of this is the best we can do is sort of say, what are the risks that are out there that we know of? People's risk tolerance really varies. And so, some patients, even if they have an E4, 2 copies of the E4 allele, where there's a higher increase of swelling and bleeding, the way that often these side effects are described, it's still percentage-wise a relatively small percent of people, on the order of a few percent, that have a more significant, severe, a non-reversible effect. Because usually, even when people are symptomatic with these side effects, they're reversible. It's actually only in about 1% to 2%, 1% in lecanemab, 2% in donanemab, where it's a more sustained, very serious side effect. But people vary very much. Some people say, I want to do anything I can to stay where I am now for as long as we can. And I accept, a 5% risk of a more serious outcome, a 10% risk of a more serious outcome. And so a lot of this, I do think, ultimately comes down to conversations between patients and their physician and their families in terms of, what's acceptable to them. And we can provide guidance in terms of what we know from the data, but these are kind of personal, I think, decisions.
Thank you so much, Dr. Arnold and Dr. Wolk, for so generously sharing your experience and for answering our audience's questions. I wish we had more time to answer more. Before we end, I'd like to remind the audience to please remain on the roundtable until we end, so that we can launch our final poll on your screen. We want your feedback, and we plan to put your feedback to good use. Also, just a reminder to please continue to support us by listening to the Bob's Last Marathon podcast. Follow us on Facebook, Instagram, and Twitter. Today's roundtable will be available on YouTube. You can find the link on bobsmarathon.com. And finally, stay tuned for my upcoming Bob's Last Marathon podcast episode titled Caregiving in Mental Health, airing next Wednesday, February 14th. Thank you.